Hello, my name is Dr. Leon McDougall. I'm the 121st president of the National Medical Association. Welcome to the National Medical Association Professional Development Series with the Congressional Black Caucus Foundation. Our topic today, disparities in caregiving for high-risk populations, older Americans, HIV, and COVID-19. It is my honor to introduce our moderator, Dr. Virginia A. Kane. She is Director and Chief Medical Officer of the Marion County Public Health Department and Associate Professor of Medicine at the Indiana University School of Medicine, the Infectious Disease Division. Let's welcome Dr. Kane.
So thank you, President McDougall. I'm so honored to be a part of an exciting webinar that's got some outstanding panelists. And you know, as the country continues to battle with this COVID-19 pandemic, this has been unprecedented demands on our people of color, especially as it relates to older adults and our HIV patients. So let me start out with our first panelist, and that is Dr. Charles Mouton. And Dr. Mouton is the Executive Vice President, Provost, and Dean of the School of Medicine and professor in the Department of Family Medicine at the University of Texas Medical Branch. He previously served at that same institution as Vice Dean for Academic Affairs in the School of Medicine. He has had a stellar career and on a lot of national, federal committees, and we'd like to have him present about patient care for the older adults. Dr. Mouton.
Thank you, Dr. Kane. I appreciate being invited and given this opportunity by the National Medical Association and the Congressional Black Caucus Foundation. I'm honored to be here with my fellow speakers. I'd first like to talk a little bit about racial and ethnic minorities, and particularly their demographics. When you look at the makeup, we see that we expect as 2030 comes on, about 28% of the population will be ethnic minority of those over 65. We anticipate by 2060, that number will rise to 45% of the population being ethnic minority. Next slide. The health of these older adults is important because of their role in the population. And we know that it rests within a complex set of determinants. Behavioral, societal, and structural factors play an important part in the health of these older adults, particularly as they age. Next slide. And when we talk about the manifestations of the health problems that impact these older adults as they move through their life cycle, we understand that there are certain what we call geriatric syndromes that really reflect an importance with these older adults, and one of the things we have to pay attention to when we care for them. Many of these syndromes are more prevalent as we get older. They also occur in earlier ages and to higher rates in older adults who happen to be both ethnic minorities or are living with HIV. So these syndromes now look important, particularly the ones I've highlighted in bold. Frailty, we know, increases at a higher rate in those with HIV. Osteoporosis, dementia, physical inactivity, and polypharmacy all have a significantly higher rate and occur at an earlier age in those with those patients living with HIV. And we know that it will present a more important problem as we try to care for them if they're exposed to COVID-19. Next slide. So let's talk a little bit about older Americans and COVID-19. Next slide. We know that adjusting for age, blacks are anywhere from 2.4 to 3.6 times more likely to die with a diagnosis of COVID-19 than their non-white counterparts. Non-Hispanic white counterparts. Next slide. And we also know that COVID-19 deaths increase with age, with older adults being much more likely to die from COVID than their younger counterparts. Next slide. And when we talk about older African Americans and HIV disease, there's some specific things that we have to think about, both in terms of just their general care, as well as their care during this time of the COVID-19 crisis. We know that over 50% of persons living with HIV are in the US are adults older than 50 years of age. That is a new and somewhat startling statistic. So I want to emphasize that now HIV disease is a chronic disease given what we've been able to do with medications and caring for those individuals. They're living to much longer ages. And now we're seeing that 50% of those are in adults over 50. HIV itself is a complex disease that requires a lot of understanding of the various comorbidities that are associated with it. And these comorbidities become more complex as adults age. So you have the issue of polypharmacy. Not only do you have to worry about their antiretroviral therapy, but also the other diseases that they may have, such as hypertension, diabetes, and the drugs associated with them. And often there are drug-drug interactions that have to be monitored and controlled for. There's also drug disease interactions that have to be controlled for as well when you have individuals living with HIV in as they age. We also know that you have the combined effect of both age and antiretroviral therapy on kidney function, on bone and mineral metabolism, cardiovascular disease, cognitive function, and again, as I mentioned previously, frailty. So all of these things have both a manifestation in older adults, but also compounded when they have HIV disease. And when you talk about the impact on the immune system, we know that aging is related to a decline in immune function as well as HIV. So now you have both factors impacting the immune function of older adults living with HIV. And there also is a heightened inflammatory response. We know that IL-6 and C-reactive protein levels both are elevated in individuals with HIV disease. When you start to talk about this in place of, in the era of COVID, you can see how COVID itself now starts to impact the health of these individuals. We know that COVID creates an inflammatory response in someone who already now has a heightened inflammatory state. The cytotoxic storm we know that the virus produces has an impact in adults with HIV disease. We know that the endothelial effects in these individuals also are heightened due to their chronic inflammatory state, but also their exposure to COVID-19. Now, when they're hospitalized, they're hospitalized in a situation where we know that in older adults, the longer you stay in the hospital on bed rest, the more likely you have of untoward outcomes. And actually it takes you, for every day you're hospitalized, it takes you anywhere from 1 week to 2 weeks to regain your functional status. So you can imagine when you have COVID disease with individuals having prolonged lengths of stay, the impact becomes devastating. Older adults also have muscle wasting, and that can be exacerbated by these prolonged hospital stays. And as I already mentioned, the decline in physical function. And then once they have to be put on a ventilator for respiratory problems, you have the problem of chronic lung issues, post-ventilatory syndromes, and all the effects that now are compounded in older adults once they're exposed to COVID-19. And next slide. If you talk about African Americans in particular, and having them living with both AIDS and COVID, there's a lot of societal and other issues that begin to impact our ability to care for them. The lack of access to care. We know that African Americans have poor access to care, their ability to have primary care providers caring for both their HIV and recognizing COVID early on is limited in the population. We already mentioned the issue of the inflammatory response. So you have the issue of HIV causing that increased inflammatory state, but chronic stress in African Americans leading from their experiences of racism and microaggressions, we know that that increases an inflammatory response in the population. We also know that the stigma of living with HIV can also have a detrimental effect on our ability to respond to chronic stress, and again, heightens that inflammatory response that leads to greater susceptibility and potentially worse outcomes related to COVID-19 exposure. Particularly important for the individual caring for the patient is the lack of a good evidence base. There's limited data on African Americans and elders in the clinical trials related to the treatment that has been proposed, as well as what's happening with the vaccine development. So if we don't have enough minorities, we have a limited data set, and it makes it difficult for the practitioner now to draw from the evidence base to begin to plan out adequate care for these individuals. We know that older African Americans living with HIV disease typically live in higher congregate living arrangements. They often have been reported to have poor social support, a limited ability to access resources. All of these puts them at risk for COVID, but also makes it more difficult for them to respond to the healthcare needs associated with coming down with COVID-19. And then one of the things we need to do as practitioners is make sure we continue to focus on prevention. We know that we're going into the fall of 2020, with COVID still looming strong on the horizon, but we also are entering into the flu season. And so the need to ensure that our African American elders and those living with HIV receive influenza vaccination. The jury is still out on whether or not we will have a COVID vaccine in time to go along with this, but I think that making sure that older adults get their influenza vaccine to, again, decrease the risk of that comorbidity while we're living in a time of COVID crisis is essential. Then finally, making sure that providers that are caring for older adults really screen for and manage their age-related diseases, making sure that they're screened for cardiovascular disease, hypertension, hyperlipidemia, screening for dementia and cognitive dysfunction, screening for functional decline. All of these things are important as you prepare a care plan for your older African American patients living with HIV in this time of COVID, and then making sure that they have the adequate resources. So with that, I'll stop, and I guess I'll turn it back over to Dr. Kane.
So thank you, Dr. Mewton. And as you can see, there's so many tremendous challenges that are happening with our patients, and with this COVID epidemic, some of the same hospital systems, healthcare systems are providing services not only for the COVID-19, but a huge demand for how we provide resources for HIV. And so this carries me to our next speaker, Dr. Gina Brown, who has joined the Medical Staff Affairs team and the Principal Medical Scientist at Gilead Sciences, providing HIV prevention education. An obstetrician and gynecologist by background who's had an extensive experience in HIV clinical care and research. She was a former medical officer in the NIH Office of AIDS Research and is chair their advisory council. And so we're going to have Dr. Brown continue to talk to us about the continuity of care for older adults living with HIV. Dr. Brown.
Thank you so much for inviting me to talk. I'm really excited and just very honored to speak to the Congressional Black Caucus Foundation and also to work so closely with the National Medical Association as Gilead has established this partnership. I'm going to talk a bit about HIV, COVID, and aging. Next slide. And I hope what you take away from all of today is just the health disparities are really a convergence of these two pandemics of COVID and HIV. But if we put on top of that just systemic inequities that really prevent adequate care amongst Black and African-American populations, what we're left with is tremendous health disparities in the middle of that. And I'll discuss that a bit in terms of how we look at HIV and how we look at COVID in our aging population. Next slide. So you can see on the left, which is coronavirus or COVID infections in cases per 100,000, and looking at HIV prevalence on the right, you could almost overlap these and you see that there's tremendous geographical similarity to where you're seeing the highest number of cases for COVID and for HIV. And having COVID has really drawn lots of attention to the really outstanding disparities and exclusion from healthcare services that we see with HIV prevalence, that we see the same thing happening with COVID. Next slide. There's a tremendous lifetime risk of HIV diagnosis disparity in the United States. So if you look down in blue at Black men, 1 in 20 Black men are at risk in their lifetime of having an HIV diagnosis, whereas for white men it's 1 in 132. And among Black women, it's 1 in 48, whereas for white women, it's 1 in 880. So there's a tremendous overrepresentation of risk for HIV diagnosis among Black and African-American communities. Next slide. In addition, this, as was discussed earlier, there's a tremendous overrepresentation of African-Americans in coronavirus. So if you look over to the left-hand side with the table, you're looking at mortality per 100,000. Overall mortality is 13.5, but among Blacks and African-Americans, it's 23.1, whereas among whites, it's 8.6. And if you look to the right, you can see that in different communities, despite the proportion of the population represented by Blacks and African-Americans, in the District of Columbia, 44% of the population, they're almost 80% of the deaths. In Michigan, 14% of the population and 45% of the deaths. So it continues as you look on this far right, that although African Americans are about 11 to 13% of the general population, we account for overall across the country 28% of deaths, and even more in some different geographic areas. Next slide. It's also important to recognize that, as Dr. Mouton talked about earlier, that African Americans with HIV prevalence and incidence, if you're looking at aging, HIV prevalence among people over the age of 50, people over the age of 50 are 50% of the population of individuals living with HIV. And it's not just that they're aging up. If you look to the right-hand side, when you're looking at HIV incidence or new infections, you're also seeing new infections continuing with that age group. And in fact, if you think about who's having the increase in infections, it's the younger age group of individuals, ages 20 to 29, but it's also the older age group of individuals over age 50. And we'll talk a little bit later about what that means and how we need to pay attention to older age individuals, and in particular, older age African-American individuals at greater risk for HIV. Next slide. So it was mentioned earlier, there's a tremendous overlapping illness burden when you're looking at older adults. And you can see how illnesses such as hyperlipidemia in yellow, or hypertension in yellow, dyslipidemia in yellow, cardiovascular disease in red, that those increase with age, and it's a much larger burden among people living with HIV than it is in the general age group. And not coincidentally, these hypertension, cardiovascular disease, diabetes also puts individuals at greater risk for severe morbidity and mortality from COVID-19. Next slide. Of particular importance that we're sitting in the middle of this epidemic in COVID-19, that if you look at what patients' experiences are with HIV care and HIV prevention services, that we all recognize that as the pandemic and in different areas of the country, the epidemic of COVID begins to expand, people were afraid to go to the hospital. And some of the regular services were shut down to make sure that appropriate services for patients with COVID-19 could be provided. So if you look at a small study that was done, the American Men's Internet Survey that was conducted looking at HIV testing and PrEP services, they had about 1,000 individuals. 6% said they had trouble getting an HIV test, 7% in the 15 to 24-year age group, and a greater percent in the greater than 25-year age group. So the difficulty even just getting HIV tested. And then for individuals who had HIV, they had a decrease in their ability to get services in about 27%. They had trouble making or keeping appointments as you go down the list, trouble getting their antiretroviral therapy or ART, and a decrease in their daily antiretroviral therapy usage. And that's important because what's keeping them healthy is being able to get follow-up care and being able to get their medications refilled. And if you can't do that, then their ability to stay healthy in the midst of the COVID pandemic is impacted considerably. And if they get sick in the midst of the COVID pandemic, their ability to access care is actually decreased because a lot of those essential services were essentially shut down for the ability to provide services for COVID-19, in particular in areas like New York and other really high prevalence COVID areas. Next slide. Can you point through that? Just click through that. So we have an ability, nope, back one slide, please. So we have an ability actually to prevent HIV infection. And it means it's all circled around getting appropriate care. So if you look at treatment as prevention, if you have an individual with HIV, if you can keep the amount of virus that's detectable in their body down to undetectable, and that's done by taking their medication and staying on their antiretroviral medication, you can keep them from passing the virus on to their sexual partners. They'll have virtually no transmission to their sexual partners if they're using their treatment as prevention. So they're taking their HIV medicine, undetectable viral load, won't pass it on. The other thing we have is post-exposure prophylaxis. If someone may have been exposed, sexual assault, having sex without prevention or protection, then you can keep them from acquiring the virus by virtue of giving them post-exposure prophylaxis or a full antiretroviral regimen for a month. But in order to access any of those, you have to be able to get to care. So emergency rooms, people were afraid to go, so they weren't getting their post-exposure prophylaxis. People were unable to get appointments, so they weren't getting their treatment as prevention. And all of those worked against being able to prevent HIV infection. And then we have pre-exposure prophylaxis, which is PrEP, 2 medications that are available, but it also involves having to get to a clinician, getting your HIV test, and then recognizing that you don't have underlying renal or kidney disease. And in particular, the newer drug, which is quite useful for older adults because it has minimal renal effects. It's called, the original drug was called Truvada. The newer drug is called Descovy. It's of particular importance and utility for older adults because it prevents bone loss and also prevents renal dysfunction related to taking the initial drug. And so, but all of these circle around having access to care in the middle of this COVID pandemic. Next slide, please. We know that if you use pre-exposure prophylaxis, it works. And you can see over time as PrEP was approved in 2012, and by 2017, you can see the decrease in the number of new HIV infections. Next slide. It's a single pill once a day. It's 2 drugs in that single pill, and individuals need to take it once a day. And the utility of the newer drug Descovy is if a person has a creatinine clearance of less than 30, which is very, very severe renal disease, they can't use it. But the previous drug is you needed to have a creatinine clearance at least of 60 for using Truvada. So there's the ability to use this new drug in older patients, and in particular in patients who may be on chronic hemodialysis. And you may wonder why I talk about this when we're talking about older patients, but in fact, they are still at risk and still acquiring HIV infection, despite having some of the morbidities that were talked about by Dr. Mouton, and also having some of the lack of mobility that was also talked about, individuals of older age being at greater risk. And next slide. Despite that, if you look at the use of pre-exposure prophylaxis, looking at it by age, looking at it by gender, you can see that in blue, over time, there's been an increase in its usage, but among whites, and you can see a much smaller increase in its usage among the individuals at greater risk. and that's among Black and African Americans. So to put this all together, you can take that slide down. It's important for us as practitioners to look at this sort of status neutral. If you're taking care of individuals, you need to offer HIV testing and they need to have access to care. If they're living with HIV and they've been diagnosed, you need to maintain them in access to care, keep their viral load down, prevent the other, and address the other illnesses that may be associated with their age, but also associated with their HIV. And if they're HIV uninfected, you need to continue their HIV testing, make sure they stay in care, but then offer them prevention and prevention services. And for both groups, the education. So it's a full circle of being able to offer these services and to prevent HIV in our communities, but actually being able to take care of it adequately, even in the midst of the COVID pandemic, making sure that any of these folks can get access to care, because that's the bottom line. And that eliminates the disparities that can exist if they get good quality care. Thank you.
To eliminate, we have it within our ability, based on the new tools that we have and the medications we have available, to eliminate HIV. And thank you for talking about the care that's taking place in our community, with so many of our patients have lack of access to quality, affordable care, and even the inability to engage in prevention or treatment. So we have our work cut out for us, and we appreciate some of the tips that you have brought to the audience. But let me go to the next area, and that is, we're finding that African-American seniors are more likely to be dependent on a relative for care. And often that care is given at home without additional support from other caregivers. And a lot of our African-American caregivers are often more likely to also have full employment outside of the home. Here with us is our next panel speaker, and that is Ms. Rita Schuler, who is the director of the Caregiving Projects with the AARP Public Policy Institute. She's developed programs and tools that enable healthcare professionals to better recognize and support family caregivers across many settings. And without further ado, she's going to talk to us today about the challenges for these family caregivers and ways in which providers can assist caregivers. Ms. Schuler.
Thank you, Dr. Kane, for the wonderful introduction, and special thanks to the National Medical Association and the Congressional Black Caucus Foundation for hosting a webinar on such an important topic. Family caregiving is a priority issue at AARP, and I'm pleased to be able to talk more about family caregivers, particularly in this challenging time. Oftentimes when we think about family caregivers, we think about that person sitting next to someone needing that care. We think about them as the mother, the father, the friend, the daughter. What we really need to begin to understand is, who is that family caregiver? Next slide, please. I wanted to present a few statistics around who African-American family caregivers are. We know that 1 in 4 African-Americans are caring for an adult who is 18 plus. We also know that 53% of African-American family caregivers are under the age of 50. All too often, we have in our mind a stereotype of who that family caregiver is. But the more we understand, the different responsibilities and roles that these family caregivers play, as well as the different generations who are providing that care, the more we are better able to provide support for them. We often think of a family caregiver as being female. We know that increasingly family caregivers are male. This is something that is not traditionally thought of when we think about somebody taking care of family. We also know that family caregivers are working. As Dr. Kane said, the majority of African-American family caregivers are working, and within that portion, 55% of them are hourly workers. Additionally, we know that 55% report at least one financial impact, meaning that in their role as family caregiver, where are they taking a hit financially and providing that support? Next slide. We know that now caregivers are facing longer and more complicated care situations. It's not just about my mom fell and broke her hip and dealing with a very acute situation. African American family caregivers on average are providing 5.2 years of care. And within that time caregiving, many African American caregivers are providing up to 31.2 hours a week. We know that is more than a part-time job. So in addition to working full-time, many African American caregivers are also working a part-time job at home as well. Many of the issues that family caregivers are responsible for caring for are supporting someone with dementia and other memory issues. Increasingly, we see family caregivers having to support someone with mental health issues and other emotional issues, as well as managing multiple conditions. I think it was timely for me to be able to speak about family caregivers after my esteemed panelists were able to speak, as they both talked very much about the complexity of care. What we often don't see is that family caregiver behind the scene. So while the patient is dealing with the care, the family caregiver is often providing that support and navigating and coordinating this care with physicians and other healthcare and social service workers. Next slide. 40% of caregivers are in a high intensity caregiving situation. And when we talk about high intensity, that means it's high number of hours of care, it's high stress and anxiety that goes along with that care, as well as the number of hours in providing it and the complexity that goes along with that. We know that African American caregivers are more often, in a high intensity care situation than non-Hispanic whites or Asian American caregivers. Next slide. One of the more concerning things that comes out of a recent study that AARP and the National Alliance for Caregiving released just in May of this year is around the health status of caregivers. We know that it has declined over 5 years. And very concerning is that only 34% of African American caregivers report their health being excellent or very good. 19% of African American family caregivers actually report their caregiving situation making their health worse. So on top of providing and supporting an individual, one or more individuals in the household, family caregivers, African American family caregivers themselves are saying, I'm not doing well. I'm not able to take care of myself because of the situation of me providing that care for someone else. Next slide. So what are family caregivers saying? We need to help empower caregivers as partners. So often we hear from family caregivers that they feel invisible. No one likes to feel invisible. As important as healthcare professionals are, it is very important for these professionals to recognize these family caregivers as part of the care team. Too often we hear family caregivers say, no one wants to talk to me. No one asks me how I am doing until it's time for me, my loved one, to be discharged from the hospital, until someone needs me to go get a prescription. Then all of a sudden, I'm the most important person in the room. And so as healthcare professionals, I feel it is very important to support that family caregiver and recognize their needs and talk to them about the things that they are needing. Their concerns are keeping their care recipients safe at home, managing emotional and physical stress, not just for who they're caring for, but for themselves as well. And increasingly, we're seeing things such as making end-of-life decisions. When we talk about these things in the context of African American family caregivers, we also have to understand its nuance within the African American culture. We understand that too often within the culture, there's a taboo around talking about end of life. There's a taboo in talking about mental health. And so it's important that healthcare providers are truly able to begin to break down some of those stereotypes and support family caregivers. Next slide. Caregiving can be lonely. Another stereotype, particularly within the African American community, is that we have lots of family around us. We have lots of friends, that we're not doing this alone. But caregivers in general strongly disagree. Over 20% of family caregivers say, even with people around me, I feel alone because I am that individual who is in charge. I need help. And back to the feeling of being invisible, nobody cares about me. And so there are feelings of isolation. And as we know, and as research shows, social isolation can be deadly. Next slide. I want to quickly pivot to African American caregivers and COVID-19. As we know, caregiving is very challenging on a good day. And so now when we overlay COVID-19 with that, we know that family caregivers, particularly African American family caregivers, are highly stressed. Why is this? Often in our community, in the African American community, as they are essential workers. They are having to leave the household and go into occupations such as retail, such as healthcare, working in long-term care facilities. And there is a fear that they are going to bring the disease back, the virus back home to their loved ones. And so how do they manage that? There's been a lot of conversation of, being able to work from home. But in the African American community, that is not always the case. And more often than not, that is not likely the case. And so how do we support those individuals who have to leave the home, who cannot stay safe at home, as the phrase that is being used broadly goes? We know that African American caregivers are more likely to be members of multi-generational households. So now that children are going back to school, whether it's elementary school or college, too often family caregivers are faced with having to manage the health of the older adult at home, and then concerns with the family member or the young child that is going out and coming back home. How do you manage that? What does that look like in a multi-generational household? We know that African Americans more often live in areas of high housing density. Again, they're close to each other. So as we begin to develop programs, as we begin to offer educational insights to help prevent the spread of COVID-19, it's very important to keep that in mind. Lack of access to quality foods. One of the things that I see often recommended to caregivers is to call delivery companies to come and bring the food. But if you live in a community where within that community there is not access to food and healthy food in the first place, or even delivery, then what is the option for that family member then? Too often it is to get on transportation, thus putting yourself at risk, to get to another community to get the food and the staples that you need for your family. And then finally, racial bias in the healthcare system and lack of quality healthcare. As an African American family caregiver who before COVID was concerned with being an advocate for their family member or friend and being taken seriously when you talk about the pain and the ailments that those who they're caring for are experiencing. Now with COVID-19, there is an even heightened risk and concern for African American family caregivers. So in closing, I think it's extremely important for family caregiving in general, but for healthcare providers to, again, recognize the complexity of family caregivers, to recognize that for every one family caregiver you see one family caregiver, and to take the time out to have conversations with that family caregiver who, although you are the professional, it is important to understand that that family caregiver is home with that person each and every day and has the experience day in and day out of supporting that person. And so making sure that that individual is part of the care team and is supported as such is highly important. Thank you.
So thank you to all of our panels. And then we'll get into a round table discussion, and we have some questions already that have been sent to us related to the different topics that we have discussed today. So the first question, I believe, is maybe anyone can jump in, but why are older adults left out of discussion about HIV?
I think there are a few reasons. I'll start off with this. And one is that when we look at the greatest risk factor for HIV infection, it's transmission via sex. And when you're talking about people over the age of 50, it's as though people over the age of 50 never have sex. And so if providers can do nothing else, it's building, taking a good sexual history and doing STI testing into their care. And once you know these things about your patients, then you can also talk with them adequately about if they're living with HIV, how do they prevent transmitting to their partners by keeping their viral load undetectable? But if they're not living with HIV, how do they protect themselves from getting HIV? And that's using, along with behavioral modifications, fewer partners, knowing their partner's HIV status, but also taking advantage of pre-exposure prophylaxis and having access. And then the third thing I think that's also quite important is, again, in the midst of COVID, these issues of having access to care are increasingly important because people are letting minor things slide, or their fear of going to an emergency room or going to their doctor because they might get COVID, so they're not getting the kind of care they need. Really providing education and encouraging our patients over the age of 50 to get care when they need it, to keep up with their regular maintenance and care, and to bring up their issues of sex and sexual activity to their providers if the provider doesn't bring it up to them. And also to recognize that they themselves may be at risk for HIV and bring up those issues for discussion to be able to get prevention.
So do we know what some of those risk factors are for COVID-19 and people living with HIV? Anyone? Dr. Mewton, maybe?
Yeah, I think there's several sets of risk factors. There's the immune-related risk factors. We know that older individuals have impaired B and T cell function. This is also exacerbated by their HIV status, although we know that if they're controlled with their ART therapies, they are probably at similar risk to older adults. But they still can have those impaired B cell and T cell humoral response functions, and so that puts them at risk for COVID. The other thing, if you look at a series from Mass General Hospital, they looked at about 47 patients with COVID and HIV disease. They found that 77% of them were non-Hispanic Blacks. 85% of them had a number of comorbidities that put them at risk for COVID. 33% had obesity, 31% hypertension, 22% diabetes, 22% hyperlipidemia, 22% had chronic kidney disease. And looking at Mount Sinai Hospital, they did a case control study, and they found that patients with HIV disease and COVID matched to non-HIV patients showed really no difference on severity or outcomes when admitted. But again, the concern was with the severity of the disease given their immune response. So the big issue is you have to have it controlled by therapies to limit your risk in the world of COVID.
So some of these underlying healthcare factors, they're influencing our minority susceptibility. Is that what you're saying? Because they have chronic medical illnesses like that hypertension, right, obesity, or asthma, or renal failure. So, or is it some kind of genetic? Do we have some kind of genes that make us more susceptible to COVID-19?
Yeah, I don't think.
I don't have any data about genes,
No.
genetic susceptibility. It really is like I said, all of those other things, the social environmental factors
Exactly.
that have now been introduced to have an impact on health. So we already talked about some of those being living situations, inability to get access to care, multi-generational households, high density households. All of those put you at risk for COVID transmission. And if you now have HIV disease underlying that again, it makes your susceptibility go up. And then if you couple that with lack of insurance, lack of access to care, stigma, chronic stress, all of those things now making your ability to fight off an infection and decreasing your ability to seek care early enough in the infectious process that you now start to have the ravages of COVID-19 taking hold in our community.
I also think it's important to point out it's with HIV, seeing these comorbidities at younger ages, seeing these other illnesses like hypertension and cardiac disease and at younger ages, that probably plays a role as opposed to only HIV itself. But it's if you're not controlled, but also if you have these underlying medical conditions that influences your morbidity and ultimate mortality that we see at younger ages in individuals living with HIV.
So I'm going to move a little bit over to the family caregivers, and what struck me, Ms. Shula, that the particular challenges that Black family caregivers face in the midst of providing care, and I think you said that almost over 50% have like regular full-time jobs. From an economic standpoint, are there any opportunities for caregivers to be paid for doing caregivers for their patients, because that might solve them having to be so stressed with like having two jobs at the same time, but concerned about the finances?
Right. That's, actually on our Caregiving Resource Center site from family caregivers and those that call into ARP, that is actually the #1 question that we get from family caregivers is, how can I get paid? And unfortunately, the answer is there are not enough ways for family caregivers to be paid. We are looking, ARP is very much supportive of tax credits, a caregiver tax credit for family caregivers. And in some states, through Medicaid, which is very limited to Medicaid, there are some opportunities for family caregivers to receive payment for the services that they provide. But those are very complex. And they're not as broad as it should be. So this, again, is an area that is very important because African-American caregivers in particular are doing this without access to any type of outside caregiving. So outside paid help to help provide that care. So anything that can be done to really support, particularly that working caregiver who, as you just said, are doing two jobs, is very crucial.
Well, I was struck by the comments you made as though some of the caregivers feel like they're invisible.
Yes.
And so now how do we get our healthcare professionals to better recognize and support the needs of these family caregivers, especially in our communities of color?
It's really about communication. Again, it's all too often when a family caregiver, and when I say family caregiver, I say it very broadly. So we're talking about family and friends who are providing care to someone. They're seen as that person. There's this assumption that they are there, particularly in the African-American community, that they love the person that they're providing that care for and that they'll do anything at any cost to provide that care. And while this may be true, we cannot take advantage of that. And as professionals, we have to recognize that that care can come at a cost. And so what can these professionals, healthcare and social service professionals, do to say, how can I help you? If you're explaining a procedure or explaining something that a complex care task that a family caregiver is going to need to do for someone at home, giving injections, providing wound care, changing a catheter. These are very complex care tasks that people
They are.
for, and family caregivers didn't go to school for. And the assumption is, I'm going to hand you a piece of paper and you're going to be able to figure that out. And so we have to be very intentional as professionals to say, here's what the task is. Do you understand it? Do you have the resources at home to do this? Do you need additional help? And I know, and we hear very often from professionals, I don't have time to have that conversation. Well, AARP and other organizations are working to ensure that healthcare professionals do understand how to bring that conversation into the course of what they're talking about with the patient anyway. And again, it's just that recognition that this person does not automatically know what they're doing and that they need assistance.
Gotcha. So now, how can we better serve older adults living with or at risk for HIV during this COVID pandemic? Dr. Brown, maybe?
Yeah, I think community education is really important. And where I live, there have been service announcements, et cetera, that you need to get your regular care, that don't let fear of COVID keep you out of your physician's office, your nurse practitioner's office, seeing your PA. And also, if you're having an emergent issue, to go to the emergency room. I think we need to do more about the community education part of it, but we also need to make sure that our clinical services are available. I mean, there have been a number of clinicians who, during the time of COVID, they didn't have the capacity in their own offices to maintain the issues of social distancing. And so many of them would shut down during sort of the height of the pandemic in New York. And then getting back up and running again has been difficult. So it's recognizing that we need to make available places for people to get care, both as walk-in, but also the ability to get their regular care visits. I think that's the key, is to maintaining your health during this time of the pandemic and without the fear of actually acquiring COVID. And that's going to be both sides, community education and clinical education.
So Dean Mouton, you've been in primary care for the longest and one of the leading authorities in that area. That's fine if we got a provider, but what do we say about the person who doesn't have a provider and may use emergency rooms for their care? And do you know, like going to emergency room for a simple sore throat costs over nearly $1,000? People are not aware of the economic impact, and they see that hospital bill and they're in shock. So what do you say? How do we reach the folks who don't have access to health care for our people of color?
Well, and that's the challenge of the U.S. healthcare system generally. It's not just an issue of HIV disease, it's an issue of any chronic disease in America. We have overutilization of emergency departments. We have issues with our public health infrastructure. We now have to turn to community health systems to really invest in them into a way that all can be assured of care. I think that one of the things that's crucial is, again, getting the message out that every American needs a primary care physician. And if we can get that coupled with a robust public health infrastructure, now we can start to provide the kind of care you're talking about. I just want to add on another piece of Dr. Brown's point. We now have the opportunity to use telemedicine.
Yes.
While the COVID crisis may have made it a little bit more difficult for the in-person face, we need to have the infrastructure now in place to begin to develop telemedicine. And what it means is that for our minority communities, we have to get the connectivity infrastructure in place so they can participate in that. So these things are happening rapidly, but all too often our minority communities don't have the infrastructure, they don't have the primary care networks, they don't have the social resources, they don't have the food and care. And all of those things are multiple impacts that make it much more difficult to care for them. And so all of those need to be fixed in terms of us making a better go of it in caring for patients being exposed to COVID, living with HIV disease.
I have to say that
So I'm going to give you, yes, go on, Dr. Brown.
one of the few benefits that we've gotten from the coronavirus pandemic is the healthcare systems have dragged their feet around telemedicine and telehealth. And it required for systems to really get moving very quickly and develop processes for telehealth and telemedicine, including the billing that goes along with it. That may be the major outcome that's at all positive about any of this.
So I've got one question. You got 1 minute. What do you think, anything that you haven't said that you think can improve the health outcome for people of color with HIV, what would that be? Ms. Schuler, 1 minute.
Coming from a family caregiving standpoint, those with HIV that have family members and friends who need that support and training to better care not only for the person with HIV, but care for themselves. It's very crucial that we provide those resources and tools, and that family caregiver is considered, again, part of that care team.
Dr. Muten.
I would say that the one thing we should use this opportunity to look at our public health and healthcare infrastructure, to build it up to where it provides adequate access and adequate care to all populations, and doing it in such a way that we bring both social services, nutritional services, all the things that our patients need to bear to make sure that they live a healthy life as they move forward in aging.
Dr. Brown.
Community education and provider education about HIV management and HIV prevention. Recognizing that HIV prevention is not specialty, it's something that any community care provider can do. It's very simple, and we need to talk with our patients about it, but we also need our patients to understand what their risks may be. So I think it's education on both sides, in the community and then also within the care system.
So I want to thank all of our panelists for providing their perspective and talking about the challenges, but they also brought some solutions. And so I'd like to have closing remarks now by our president, Dr. Leon McDougall.
Thank you, Dr. Kane. What a wonderful discussion. And in regards to telehealth, telemedicine, I think we need to continue to advocate for CMS to provide reimbursement that will continue encouragement of providers to be able to maintain that connectivity. And all you really need is a telephone, and electronic medical record on the provider side, and so on. So stay tuned, and thanks for watching this broadcast. Our next professional development series will air on September 23rd at 1 p.m. It's entitled Increasing Diversity in Clinical Trials for Better Public Health Outcomes. What a timely topic. So long.